All right. So we are having a debate. I don't know where the debate is, but let's start the topic from here itself. And we are discussing how residual node positive axilla post chemotherapy in breast cancer should be treated, whether it should be surgery or radiation. And being a surgeon, I am for surgery, but that's not the only reason why I am for surgery. Why did this debate start? And where did it actually stem from? So if you look at early breast cancer, and I'm stressing on it, early breast cancer, node negative early breast cancers is where we started discussing about sentinel node positive patients to be treated with completion clearance or to be treated by radiation. Why? Because we needed to reduce the morbidity of the surgery. And what did it show? What was the endpoint of this AMAROS? The primary endpoint was a five-year axillary recurrence, and it was a non-inferiority, saying that RT is not inferior to doing a complete dissection. And the secondary endpoint was DFS and OS. If you look at the results, the lymph node dissection did have a higher morbidity with the early morbidity that you see with any surgery, and also a slightly higher lymphedema rate as compared to radiation. But mind you, radiation also had a lymphedema rate of 9%. Also, the dysfunction that was there in the shoulder was seen with radiation, but did not last beyond 4 to 5 years. So this was where we stood. That means we have more morbidity, you have no impact on the survival, and probably a non-inferiority. And as happens in every treatment, whether it is systemic therapy or not, anything in the early breast cancer gets translated into advanced cancers. And which is where we started discussing about the radiation to be moved to locally advanced cancers. Now, the other trial with an 8-year update, which was the optimal treatment of axilla, surgery or RT in sentinel node positive early breast cancer, again early breast cancer, said the same thing, that this was a non-inferior intervention to do radiation versus surgery. However, you have to understand that the actually post-chemo node positive cases were not what were the intent of discussion in these studies. So as a surgeon, I would say that surgeon's role in an axilla is two things. One is to predict the axilla correctly by any of the techniques, be it sentinel node, be it targeted axillary dissection, or locally low axillary sampling, and definitive would be to clear all the lymph nodes. So a surgeon's role lies with both of them, and both have to be correct. As far as a situation of post-chemo, which is our point of discussion today, when the patient is already node negative in the beginning and is remaining node negative after chemotherapy, I think it's that the decision is already made. We know that sentinel node biopsy in this situation, because this is still an early breast cancer, and these patients, especially the triple negative and HER2 positive, do get neoadjuvant chemo because of their biology, because of the adjuvant change of treatment. In these, I think there is no debate. Sentinel node biopsy can be a discussion, and we do use that to decide what to do with the axilla. Again, a sentinel node positive in this receiving RT or not is not the question. Whether you can do a sentinel node biopsy and leave the axilla alone. The next is, if there was a node positive biopsy proven lymph node, you've given chemotherapy, and now the patient is node negative. In this situation, is sentinel node biopsy alone a right decision or not? Again, the false negative rate is slightly higher, but it still would be helpful in this situation. If there is a good systemic treatment, you can still consider a patient to do sentinel node biopsy and take a decision for rest of axilla. So sentinel node biopsy in a post neoadjuvant chemotherapy situation is definitely a valid alternative to axillary lymph node dissection. None of them answer the question of radiation, is it a viable option or not? And we do know that post systemic therapy in HER2 positive and triple negative, we get much more axillary responses, and the node positives are actually smaller. So why do we have to do axillary staging, which has to be correct? That means sentinel node biopsy being the correct method. That's because in the CN1 status, confirmed node positives when they receive chemo and they become node negative. The post-neoadjuvant chemotherapy residual disease is also prognostic. And that is where it is important to understand in such situations where it is node negative upfront or those who become node negative after chemo, the regional recurrence rate is lower, whereas if it is node positive after chemotherapy, the regional recurrence rate is higher because there is risk of leaving behind disease. So we are looking at a higher axillary morbidity. And tumor biology definitely dictates this. Now if you look at the actual trials, the two trials that are important where we are talking about post-neoadjuvant sentinel node biopsy positive patients. Now these are the post-chemo N plus patients. Now here the NSABP B51 was those who converted to N0 and then you were randomizing them when there was a sentinel node positive in these patients to RT versus surgery. Now in this situation, as you can see, there was none of them were actually the patients who were node positive. These are staged by sentinel node biopsy, more than 2 lymph nodes alone or lymph node dissection. In the case of the Alliance trial or the A011202 trial, this is those where the post chemotherapy there is node positive, and with the residual axillary disease you're randomizing between ALND versus radiation, the regional nodal radiation. Now here, this trial, I will tell you more details about it in the next slide, but essentially as of today, ALND remains the standard of care for anybody who is a post-chemo node positive. Now if you look at the ALN, don't forget this, we have already discussed. Now as far as the guidelines are concerned, none of the guidelines have actually changed. The NCCN guidelines as well as the ASCO guidelines and St. Gallen's statement, 70% of the panel still favor axillary lymph node dissection. But it's important to understand that in all the trials that we've had so far with results, none of them actually are those with post-chemo node positive heavy nodal burden. Only when there is a nodal burden which is less than 2 is where you have actually looked at radiation. Now residual, as we have already said, the residual nodal burden decides the risk of recurrence, and here we do not have evidence that radiation may be actually similar to or non-inferior to axillary lymph node dissection. Bulky disease again cannot be treated with radiation, and the impact on the further treatment decisions also requires the number of nodes that are residual disease positive to be understood, which we get mostly with axillary lymph node dissection. The Alliance trial itself is looking at 2,000 patient enrollment. They have definitely completed enrollment, but there are no results published yet, and that will be available only by 2030. And even when the results are awaited, there has already been a tendency towards moving towards sentinel node biopsies in patients post chemotherapy, and especially so you see the publications that have come out, the I-SPY2 with change of surgical management, and if you look at the percentage, majority clinicians have moved towards doing sentinel node biopsy versus axillary lymph node dissection, and none of these are evidence-based. So is it right to go ahead now for leaving surgery behind, omitting axillary lymph node dissection in patients? Because there is still no evidence that is available. Even when you look at the National Cancer Database results that have been published in 2024 with data from 2012 to 21, the same data is seen that there is an omission for axillary lymph node dissection without evidence, and there is no overall survival benefit. So when the analysis was done for overall survival, again there was no benefit. So one, supported by evidence, are we here today to change practice and move to radiation versus lymph node dissection? Definitely not. I think we have to wait for these two other trials which are also accruing. One is the ALND trial, which is a similar trial, as well as the TAXIS trial or Taylor axillary surgery, both looking at the same question of node positive patients being randomized to surgery versus lymph node dissection. Until such time that we do not have this data, it is too early. None of the guidelines are recommending radiotherapy, and we continue to do axillary lymph node dissection for node positive patients, heavy nodal burden. The early breast cancers are a completely different story, and we are not discussing that today. Just because we are giving chemotherapy for virtue of it being triple negative or HER2 positive, for systemic therapy in the adjuvant settings. So thank you very much. Now I'll let my opponent prove to you and convince you that radiation is the right treatment for all these patients. Thank you very much.
Thank you, ma'am. And you're very kind for a very balanced presentation. With due respect, you're very, very senior to me, and everything that you said was correct, but I'm going to be a fighter. So, beginning, I can't see that. So, residual node positive axilla after NACT, can we omit axillary lymph node dissection and replace it with RT? I'm Dr. Ritika Harjani, Hinduja, consultant radiation oncologist at Hinduja Hospital, Mahim. And I think it's time to jump from the past to the future. And I would also say, Priyanka, you were correct. I'm backed by enthusiasm, and guidelines will follow. So are we, there was a time where we thought that one size fits all, but does it really? It's for you to say. So that's not the way, it works. Things have been changing and things are here to change, and we'll just see how and where. So as we have evolved, ma'am very well covered it, that axillary lymph node dissection previously was a standard in all situations, but we have evolved. So early breast cancer, we have even moved from situations of axillary lymph node dissection to sentinel biopsy, and even no surgery at all, no axillary surgery at all in some situations, backed by NSABP B04 CALGB trial. And then as it was shown, when the sentinel lymph node biopsy was done in a CN0 or clinically node negative, and even if there was a low volume axillary disease, as by the ACOSOG Z0011 or CINOMAC or AMAROS study, if we omitted axillary lymph node dissection and added up RT, we have very well seen that there are no differences, or RT is non-inferior to surgery in terms of axillary recurrences and other cancer outcomes. And gradually we have moved on to node positive situations also. So many a times node positive, we have, if we actually study them, there may be 1 or 2 nodes, and otherwise if they could have fit into ACOSOG, and clinically people have gone into clinically deciding without guidelines, but there is research ongoing, and we'll come to it when we cover the NACT part. And when NACT is planned, it's obviously clear that when there is nothing on the sentinel lymph node after NACT, we avoid axillary lymph node dissection and go ahead with radiation. And there are multiple studies like the OPBC04, UBreast 06, or ongoing studies like the ATNEC study. Now we come to the point of discussion, that is, there was clinically node positive disease, and we have residual disease. So it sounds very obvious that that's the situation where you would want to do axillary dissection, but what is the evidence that says? Of course, ma'am showed us some trials. I'll show us all of us some more. So there are 3 situations when we talk about post-NACT residual disease. I would label it into isolated tumor cells, micrometastasis, and macrometastasis. So coming to isolated tumor cells first. This was a study, the OPBC05 ICARO study, the International Conference of Radiation Oncologists, nodal burden and oncological outcomes in patients with residual isolated tumor cells. And in 580, this was a prospective registry. In 583 patients with isolated tumor cells from 62 centers in 18 countries, 401 did not undergo axillary lymph node dissection as per the physician's choice. And they saw that only 30% had additional positive nodes, and only 5% of them were macrometastasis. Despite some patients being micrometastatic in this situation when axillary lymph node dissection was done, the 3-year rate of any axillary or any invasive recurrence was similar, with no difference by the type of axillary surgery, omitting or not. So in terms of isolated tumor cells, I think we are quite clear with regards to this study that these results do not support routine axillary lymph node dissection in all patients with isolated tumor cells. Now coming to macro or micrometastasis, this is a trial prospective study again. Axillary lymph node dissection is not required for breast cancer patients with minimal axillary residual disease. They took T1 to T3 N1 at diagnosis who had good clinical response to neoadjuvant chemotherapy with less than or equal to 3 pathologically lymph nodes, and all patients received RT to axilla level 1, 2, 3 and SCF with or without IMC irradiation. And there was no axillary recurrence in follow-up of 44 months. So this was a good number of over 100 patients where we have seen no axillary recurrence, where RT axillary surgery was avoided. And they have been very careful, if you note, on their exclusion criteria, with pathological complete response being taken away and incomplete pathology or gross residual with more than 4 nodes they have taken away. So although they expected high recurrence rate in the axilla, the conclusion mentions that these results suggest that minimal axillary residual disease may not necessitate axillary lymph node dissection. And as we discussed that understanding the future trials, we have accepted sentinel lymph node biopsy in a YP N0 sentinel setting, and we have also in multiple studies emphasized that somewhere we need to decrease the false negative rates of these sentinel lymph node biopsies by maybe having more number of nodes dissected and improving localization techniques. And there are trials which show that there was one node and there was high sentinel node, the false negative rate. But there is a paper in the breast that sentinel lymph node biopsy, when it was done, and even if when there was a high false negative rate with only a single node or non-dual tracer techniques used or not aided with targeted axillary dissection or low axillary sampling, as ma'am mentioned, there was no difference in the disease-free survival. And to go to it, there are multiple such studies, the analysis of NACBP B40 and B41. Then there was this Turkish multicentric study where said that no difference could be detected in the local recurrence rate after the surgery, regional nodal recurrence, including axilla and SCF, between YP-N0 and YP-N plus patients. So, and then this evidence also exists from the Harvard and the National Cancer Database that despite having residual nodal burden, the overall survival did not differ by the axillary type. So, I will not go through all the studies in limit of the bell having rung. So, there are these 3 randomized trials that are coming up. One is Alliance 011202 study, which is a phase 3 study which is going to prove the role of RT in against surgery. There is another surgery studies from Spain where nodal involvement was divided into ITC micromets and macromets and RT versus surgery. And there is this OPBC taxis study. So many times people feel that we need the axillary burden so that they dictate our systemic treatment decisions, but a pilot first 500 patients from OPBC 03 study showed that the systemic therapy decisions did not differ between patients with or without ALND, and they got the information they wanted from sentinel lymph node biopsy and targeted dissection alone. Coming to radiation, we have sophisticated techniques and we have proven our efficacy across Amaros and Sinomac, which were in early breast cancer, but now we have reduced the burden post NACT to a similar situation where 1 or 2 nodes in the sentinel node are positive. And let's not forget why we are doing this. There is a reason behind this. So the lymphedema rates between sentinel lymph node biopsy and dissection are different at beyond 2 years, at 5 years. There is a statistically significant difference between the two. And we may realize or not, the NACT duration also adds to the lymphedema. There are studies which shows that NACT itself also contributes to the fibrosis and lymphedema. And quite many times I have come across some surgeons mentioning that we do axillary reverse mapping where we put a dye in the arm and realize what are the arm nodes, but that's not without limitations. There is risk of leaving metastatic nodes behind. There is anatomic overlap of breast and arm lymphatics. There is technique variability and a learning curve, inconsistent impact on lymphedema reduction across trials, and it is costly. Another thing that I have experienced patients coming to me with a lympha surgery, but I have not seen, this is anecdotal maybe, but the research also says that it is not consistently shown benefits in terms of lymphedema. Lympha is basically like a bypass surgery for the lymph vessels in the arm. And then beyond the edema, there is arm abduction, mobility, arm pain, numbness, a lot of things. And I accept that we do cause lymphedema. Radiation is not without complications, but it is relative. So when we see relatively, sentinel lymph node biopsy and nodal irradiation had a significant lower breast cancer related lymphedema risk than the axillary lymph node dissection and irradiation group, And there was no significant difference when we compared only axillary lymph node dissection versus addition of radiation. And upper arm morbidity was also more in the axillary lymph node dissection arm. And Amaros also shows that lymphedema arm across radiation and surgery is statistically significant at 1 year, 3 years, 5 years, arm circumference, and even in the updated study they say that a higher lymphedema rate is there in the 5-year and 10-year analysis. I have added the 5-year here. So, of course, in some situations you need it when there are more than 4 or 5 nodes post NACT that are grossly visible and they are glaring at you. But otherwise, even if you have the weapon or the tir command, we say you have to put it into use only when needed. And I'm sure by now we are all convinced that one size doesn't fit all. Thank you.
Am I allowed the rebuttal? So my opponent is also a friend. So I'm not going to kind of shoot that down, but let's also understand the disease. And even though you would always want to prove that your own technique is superior to the other, you have to understand both have their own side effects. And I think balancing out these side effects is where we learn what to do and what not to do. So if you have a disease which is grossly there, and I agreed with you, that wherever the disease burden is low, we can always shake hands and say radiation versus surgery. With a good surgeon, even the lymphedema rates are low. It's not as high as it's made to sound. And you have to understand what is the lymphedema you're talking about. I don't think there are so many of those gross lymphodemas that you see in the textbooks anymore. One, because your surgical techniques are better. Yes, radiation also contributes to that. When you do for a locally advanced breast cancer and you're giving radiation, don't blame the surgeon alone, because the kind of lymphodemas you've been seeing is because that patient, being node positive, would have also received radiation, and the lymphedema with radiation is an intractable lymphedema which you can't help even with a lympha surgery. Whereas surgically induced lymphedema does respond to a lympha surgery. So I think we are at a stage where we're still awaiting trials. I think it's tomfoolery to switch completely to radiation, leaving surgery. That is not where we are heading, because we still don't have evidence of it being safe. I guess we still continue to do axillary lymph node dissection, and I'm sure my opponent here would also agree, though we agree to disagree on the stage, but I think we all agree when it comes to clinical practice that lymph node dissection will be here to stay. Only in low burden you can completely discuss. With 1 node or 2 nodes positive, you can discuss the option of surgery versus radiation, depending on a lot of other conditions, and the patient has to be party to this discussion with all the information given on the plate. Your rebuttal.
So ma'am has concluded for us, and it's true. This presentation had a lot of non-randomized data. So in terms of evidence, as a take-home message and not as a rebuttal, as of today in residual node positive axillary lymph node dissection is the standard of care. Again, I don't know if I should be saying this as a rebuttal, but that is what it is. And this is probably not the very best evidence right now for moving over to radiation. But the trials of Alliance, Adarnat, OPBC, Taxis 03 will move towards radiation in low volume residual disease, which itself is a giant leap towards non-surgical or de-escalating surgical management. Thank you.
Thank you, ma'am, for very elaborate discussion on a very short time. I would try to conclude something. It's very important that we know whether there is a residual disease in axilla, because it's a prognostic implications and treatment defining information. Secondly, clinically negative after chemotherapy still need axillary surgery, to re-establish whether there is a disease or not. So even if it is clinically negative after NACT, means N positive, NACT, and now clinically it looks negative. So at least we need to explore the axilla. There is no debate on that. Yeah, so we always explore the disease. The issue is if there is a node positive and it is not clipped, then only sentinel lymph node may leave disease behind in a clipped node for almost 20% of patients. So you always need to clip the node which is biopsied. Secondly, even after clip, about 5% of those clipped nodes escape detection post NACT. So those are the patients that probably you will convert into axillary lymph node dissection because you are not adequately sampling the axilla. Second thing, if your sentinel lymph node and clip node, targeted axillary dissection, if node negative, it's fantastic. We are not doing anything further. But suppose it comes positive, then if there is no dual dye or there is a less than 2 lymph node in sentinel removed, there is higher risk that a escape node may be positive when there is a targeted and sentinel lymph node positive. So there is a very small segment where probably in our clinical practice we will be not doing ALND and offer for the radiation. Those are the patients where your 1 or 2 lymph nodes are positive, both are clipped, both are targeted dissected, and sentinel lymph node has been done, and the burden of lymph node positivity is less than 50%. Then there is a much less chance of false negative in remaining axilla, which is about 5 to 7%. So these are the patients that probably will be not gone for axillary lymph node dissection completion and go for radiation. Or otherwise, if you are not doing dual dye or your lymph node, sentinel lymph node and targeted is less than 3 lymph nodes, there is a very high chance that the disease is left behind the axilla and probably it may deteriorate your further clinical outcome. So please correct me if I am done something. Yeah, thank you.
I think we have discussed enough on the post-chemo lymph nodes, so I will say thank you very much.